It's a common symptom. So I will not cover all the aspects of headache, only the basic points I will be doing. So as you all know, headache is a universal experience. Every human being would have had at least one episode of headache. Therefore, it is a universal disease and an universal experience. And in 1 year period, the prevalence of headache is about 90%. And lifetime prevalence is 99%. And 5% of women and 2.8% of men suffer more than 180 days per year with headache. So it's a manpower depleting disease, even though it's not a serious disease always. So headache comes from direct or indirect involvement of the pain sensitive structures of the head. So when these structures are involved either directly or indirectly, headache will come. So what are these structures? One is the dura near the vessels. Then second is the sensory cranial nerves. They are the 5th nerve, 7th nerve, 9th nerve and the 10th nerve. And you have got the circle of Willis and its proximal segments, the vessels, the circle of Willis arteries and the proximal continuation of these medium-sized vessels. Then the meningeal arteries, large veins in the brain and their dura. So these are intracranial pain-sensitive structures in the head. The extracranial pain-sensitive structures are scalp, neck muscles, roots of the cervical cord, then cutaneous nerves and skin, mucosa of the paranasal sinuses, teeth, external carotid artery and its branches. And the most important thing to remember is the organ which experiences the sensation, the emotions of pain is not sensitive to pain. So brain parenchyma, that is why we can do live brain operations. So brain parenchyma is not pain sensitive. And then you have got the same location. Where is the location of the pain? So the pain, some of the pains are in the site of involvement. For example, pain coming from the cervical roots or pain coming from the sinuses. They are located in the site of the pain. Some of the pains are coming far away from the site of the pain, but experienced in some other sign. They are called referred pains or non-localizing pains, false localizing pains. So referred pain for supratentorial problems can be over the frontal area of the 5th nerve, ophthalmic division of the 5th nerve, because of the trigeminal-vascular referral from the tendorium, which is also supplied with 5th nerve. A lesion just above the tendorium might produce a pain in the face. Then infratendorial structures, that is below the tendorium, can produce a pain in the neck, C2 and C3 area. So you might think that the disease is from a wrong sides. Then cerebellar lesions produce pain in the back of the head. And occipital lesions produce pain in the frontal region because of the trigeminal-vascular reference again. Then caudal nucleus of the 5th cranial nerve, upper cervical cord and 5th cranial nerve together are irritated by lesions in the high cervical cord, and posterior fossa pain can also be referred to the frontal region. So when somebody is, so these are the pain sensitive structures, and they can produce a direct pain over the site of the pathology, or they can produce referred pain far away from the site of the pathology. What is important is whenever a patient comes with headache, the most important thing we want to know is the patient suffering from raised intracranial pressure. That is the most malignant cause for the headache. So you have to ask a question to rule it out. After that, you have time to treat the patient and diagnose. So the questions you ask when the patient comes with headache is it a short duration headache or a long duration headache? A short duration headache is a headache of less than 3 months duration, and that always has got a significance. So some underlying significant disease is there. So if the headache is short duration, see if the patient is very well preserved. And if the person is having a short duration headache and his general condition is good and is very well preserved, it could be due to fever, ENT causes, dental causes, temporomandibular joint pathology, etc. If the patient is suffering from a short duration headache and he is very sick, you will have to think of a central nervous system cause like CNS infections, hemorrhage, then
Давно не виделись.
so it can be infections, it
Давно не виделись.
can be large strokes, can be tumors.
Хендехох.
So if the patient is short duration headache and he is sick, we have to think physical problems. And if the headache,
Ты что, пикурица, что ли? Раком быстро встала?
Мозга,
Кто тебя лоб посотрелил?
Что тебе сдал? Скачала с башкой.
Кто стрелял?
some disturbance is coming. I don't know
Вас Путин стрелял?
where that is
Или
coming.
Байден?
Путин,
Somebody else is
Как
talking,
быть?
no?
Слава,
Some
Ай,
disturbance.
Раша.
А вы в Дубае живете? Где вы живете? В
Слава.
Дубае? Я сейчас в Дубае. Я тут отдыхаю. Алло.
Okay. So if the headache is of long duration, it is generally a benign headache. That is more than 3 months. Not always that cutoff can be applied. If the headache is of several years, people will tell I am suffering from headache for 10 years. Still I am not relieved. Then you need not even examine the patient. It may be a migraine headache or a tension headache. But if a person with a long duration headache claims a recent change in the nature of the headache, then you should be careful, because even a patient with migraine or even a patient with tension headache is not protected from getting a tumor. So if the long duration headache has got a recent change in the character of the headache, then give the relevance of a short duration headache. If such a thing has not happened, long duration headaches are benign. So let us see what are all the features of headache in raised intracranial pressure. One thing, usually short duration, because by the time, if not treated, patient goes into serious complications. So raised intracranial pressure produces headache, which is usually short duration. Usually it is bilateral and mostly it is occipital. Why? Because the headache of raised intracranial pressure, which may be reflected everywhere, is experienced in the occipital region. Is it because auto-regulation is slightly inadequate in the occipital region. So when the intracranial pressure builds up, auto-regulation fails most in the posterior region. Therefore, headache is experienced in the occipital region. The nocturnal awakening. So a patient with a headache wakes up in the middle of the sleep with a headache, means it is raised intracranial pressure. Why that is happening? Because we start our sleep with non-rapid eye movement sleep. So we start sleeping with NREM, where the pressure fluctuations are very much less. And halfway through the sleep, we go into rapid eye movement sleep or REM sleep. REM sleep has got naturally fluctuating intracranial pressure. High pressure waves are there, normally happening in rapid eye movement phase of the sleep. So when there is already compromised brain due to a mass lesion, which is producing raised intracranial pressure, but brain is slightly compliant with the mass lesion, when the high pressure waves of rapid eye movement sleeps are overlapped on that, patient will wake up with headache. So nocturnal awakening happens when the REM sleep induced pressure fluctuations decompensate the brain compliance and ICP becomes manifest in REM sleep. And early morning awakening and early morning waking. That is also for the same reason only. We fall asleep with NREM and we wake up with REM. And when there is REM, there is fluctuations. And these fluctuations produce decompensation of the brain compliance and ICP becomes symptomatic. Next is amaurosis fugax. What is amaurosis fugax? Is transient blurring of vision. So in patients with raised intracranial pressure, headache can be associated with transient blurring of vision when head position changes. This is supposed to be due to two reasons. One is the brain parenchyma getting compressed over the tendorium, which is a tendorial incisura, very narrow space. You have got a supratentorial compartment and we have got an infratentorial compartment. The region in between is the tendorial incisura, where the posterior cerebral artery is lying. So when the head position is changed, the posterior cerebral artery gets stretched against the tendorium, resulting in occipital lobe ischemia. That is one reason for amaurosis fugax. And another reason is optic nerve head edema is there. And this edema fluid, when you move our head, can shift in the ganglion cell layer, resulting in transient blurring of vision. These are the two reasons for amaurosis fugax. And double vision, whenever there is a right intracranial pressure, the false localizing sign. For example, if you take the cyst nerve, it is having a large intracranial course from the orbit to the pons. In that course, it is anchored in the petrous bone, in the Dolores canal, in the medial petrous region, and it gets stretched from its anchorage to the Dolores canal anteriorly and posteriorly, resulting in dysfunction of the sixth nerve and double vision, false localizing dysfunction. Then, so these are, if these things are there, we have to understand that my patient is having a grievous problem and he has to be investigated properly. And then, is the ICP associated with focal deficit or without focal deficit? If the patient says that I am having mild weakness in my right upper limb, then you know the pathology is on the contralateral side. But if the patient has got all the features of raised intracranial pressure, but he does not have any focal sign, it may be due to medical causes like idiopathic intracranial hypertension, metabolic conditions, chronic obstructive airway disease producing carbon dioxide narcosis. So raised intracranial pressure can be due to medical or surgical conditions. And if there is a focal deficit associated with raised intracranial pressure, always look for a structural pathology. And if there is no focal neurological deficit, it may be a medical conditions like benign intracranial hypertension or cerebral venous thrombosis, chronic meningitis. These situations, there can be ICP without focal deficits. Next question we ask, so we now know whether the patient is having raised intracranial pressure or not for his headache. And if he has raised intracranial pressure, it is due to a focal pathology or due to general conditions like benign intracranial hypertension, deep CVT, or due to chronic meningitis where the ICP occurs without focal signs. Next thing, what symptomatology of the headache. If the patient's headache is aggravated by lying down. So when the patient says that when I sit up, I am comfortable. When I lie down, my headache is worse. Then you think of posterior fossa tumors, chronic subdural hematomas, idiopathic intracranial hypertension, and frontal sinusitis. So these are the headaches which are aggravated by lying down. If the patient says that my headache is better when I am lying down and it worsens when I sit up, it is intracranial hypotension. This usually happens in post-lumbar puncture headache. So if the patient's headache is aggravated severely by sitting up and relieved by lying down, it is intracranial hypotension, usually happens following lumbar puncture. So this is a fundus. So now we are seeing that our patient has got raised intracranial pressure and we have to describe the fundus. That's the first examination we do. So you look at the physiological cup. The physiological cup is not at all visible. It is filled up. Color of the disc. So cup is filled up, not at all seen as the depression which you normally see. The color of the disc is angry and reddish looking. Contour of the disc is not at all seen. We are not seeing the contour of the disc. It is merged in the edema fluid. Vessels crossing the disc. The vessels crossing the disc become little more dilated and they may show exudates around. So that is called sheathing. So vessels crossing the disc appears engorged and they are sheathed with the chronic edema around the vessels. So cup is filled up, color is angry, contour is blurred, vessels are slightly dilated and sheathed, and peridiscal area is edematous, and peridiscal area shows hemorrhages. So this is raised intracranial pressure. And venous pulsations will be absent. That is possible only in the video. So this is a photograph where we do not demonstrate the venous pulsation. So arteries sheathing, engaged, and venous pulsations become absent, and peridiscal hemorrhages and edema. So this is classical severe papilledema. So now optic nerve head swelling can happen due to optic neuritis and papilledema. How are you going to differentiate optic neuritis from papilledema? So optic neuritis, pupil will be abnormal, whereas in papilledema, pupil will be normal. So in optic neuritis, vision is very bad because patient has central scotoma or centrocecal scotoma. In papilledema, the vision is only peripheral constriction of the field of vision. They do not have any acute loss. And optic neuritis, as I said, central scotoma, whereas field is constricted and enlarged blind spot in papilledema. This swelling, if you measure, it is less than 3 diopters in optic neuritis, and it is more than 3 diopters in papilledema. Patterns line, that is the folding of the retinal layers around the optic nerve head, is not seen in optic neuritis. This retinal edema produces folds around the optic disc in papilledema. And peripapillary hemorrhages are usually not seen in optic neuritis, but sometimes it can be seen in conditions like methyl alcohol poisoning and Lee's disease, etc. But generally, optic neuritis does not show hemorrhages, whereas we saw the hemorrhages in the papilledema. Venous pulsations are preserved in optic neuritis. They are absent in papilledema. Retinomacular nerve cell layer is normal in optic neuritis. The papilledema is due to medical causes like hypertensive encephalopathy, vasculitis, renal disease, then macula will be abnormal. If the papilledema is due to mass lesions, macula will be normal. So now, so this is the most important questions we have answered, and we have seen the fundus also. Then we will see briefly the scan negative headaches. Each headache itself is a huge topic. So scan negative headache, we will see the CT scan is normal, so there is no tumor. So under this, you have got the primary headaches. What are they? Migraine headache, tension type headache, cluster headache, chronic paroxysmal hemicrania, and miscellaneous headaches like idiopathic stabbing headache, benign exertional headache, cold-induced headache, external decompression headache, and benign cough headaches. Secondary headaches are head trauma, head injury. Then vascular disorders like strokes, subarachnoid hemorrhage, arteriovenous malformation, arteritis, and cerebral venous thrombosis, hypertension, encephalopathy. These are vascular causes. Secondary headache is due to some symptomatic. It's a scans positive headache. Previous one is a scan negative headache or the primary headache. Secondary headaches are scan positive headache. Then non-vascular intracranial disorders like tumors, abscess, substance abuse or withdrawal can produce headache. After chronic alcohol or chronic smoking, patients can have severe headache. And non-cephalic infections, systemic viral or bacterial infections can produce headache. And metabolic disorders like hypoxia, hypercapnia, hypoglycemia, dialysis disequilibrium syndromes, they can also produce headache. And headache associated with disorders of the neck, skull, eyes, ears, nose, sinuses, teeth, and mouth. And we have got various neuralgias like glossopharyngeal neuralgia, trigeminal neuralgia, and pain coming from the various nerve trunks. They are all secondary headaches. So headache is short duration versus long duration, ICP versus no ICP, primary headache versus secondary headache. Now, how are you going to take the history? So you have to take the time scale, the age at which the headache started. Usually migraine headaches start around the first decade. And time to maximum intensity. That will help us to know whether it is a short duration headache or long duration headache. At onset to peak time, how much is the time? Onset to peak is 2 to 3 months, means you think of a ICP. If it is long, more than 3 months, then you think of medical benign condition. Frequency, is it a daily headache or what is the frequency of the headache? And which time of the day it is worse, like nocturnal awakening, early morning vomiting, I said it is ICP. Whereas headache in the evening, maybe tension headache. So the time of the day, the headache is coming. Duration, the headache is lasting for how long? Is it in a cluster, like cluster headaches? And how often it is recurring? And what are all the features that precipitate a recurrence? So that is about the time scale. Then you think of the other features. Where is the headache? What is the quality? It is neuralgic. Is it pulsatile? Or is it throbbing? Or is it a pressure-like sensation? Or it is like a thunderclap? And how severe it is? So location, quality, and severity. Then associated symptoms before the headache like aura, during the headache like vomiting, and after the headache like tiredness or mood changes. So what are all the associated symptoms before, during, and after the headache we have to ask. And any specific precipitating or aggravating factors like head injury, medical conditions like systemic infections, and any specific trigger like exposure to sound, light, or starvation, television, cinema, no? Watching mobile too much. Is there any trigger zone, any specific part of the neuraxis like neuralgic pains, any specific activity like exertion, or any pharmacological agents like nitrites? So these are all these we should identify so that we can help the patient. And relieving factors, is it non-pharmacological like rest and sleep, or is it always pharmacological? Then evaluation and treatment history. So previously, before coming to us, what are all the evaluations done and what are all the treatments received? Then we know those treatments are not helping the patient and you have to think of alternative treatment. So knowing the history of evaluation and treatment is very useful. Then psychosocial history like substance use, occupational and personal life, psychosocial history, sleep history, impact of headache on his activity, disability adjusted life years, DALI. So is the headache disturbing his life years? That is very important. And is the patient having his own diagnosis? Patient may have a sinusitis or a migraine headache, but he will diagnose tumor for himself. Because of that, he will refuse to go for job. And is there any family history like migraine? Family history is often there. And complete medical and surgical history in the past. Supposing he has a tumor operated some 5-6 years ago, it might be producing a late metastasis. So all those things are very relevant. After that, we are starting to examine the patient, the vitals like pulse rate, blood pressure, fever, examine the oropharynx, any trigger points like neuralgic pain, temporomandibular joint tenderness, clicking sound, limitation of movement, sinuses, arteries, temporal artery, carotid artery, indurations, pulse and bruits, and skin, rash, Kefioli spot, and tenderness. Then Kefioli spot are associated with the neurofibromas. So that is why we have to look for that. Then fundus examination, as we saw, the cup color of the disc, contour of the disc, peridiscal area, macula, all this gives lot of information. Then what about the pupil? What about the cranial nerve functions? If there are mass lesions, cerebral open and angle tumor, we might find fifth nerve. And depending on the site of the pathology, we might find signs. Then signs of meningeal irritation, neck stiffness, or Brodsky sign, or Lasgue sign. Are they there so that we know there is a meningeal irritation or not? Then when are we going to? So now we have looked for features of the patient's headache, and then we have to decide whether the neuroimaging is indicated or not. So we have to do the neuroimaging if the patient's headache is the worst ever headache in his life. Like something burst in his head. I have never had a headache like this. It may be a subarachnoid hemorrhage. So the worst first headache should be investigated. And subacute headache with increasing frequency of severity and character. That may be a slow-growing mass lesion. So you have to investigate that. And progressive or new daily persistent headache. New daily persistent headache. Old daily headache is a chronic daily headache. Whereas a new daily persisting headache may be due to a focal pachymeningitis, leptomeningitis, or mass lesions infiltrating into the meninges at that site. So it is important, or osteomyelitis of the skull. Then headache always on the same side. You have to look for an underlying lesion. Usually the classical migraine headache alternates, tension headaches are diffuse. So if a headache is always on one side, you have to be careful. And headache in patients with cancer or HIV, we have to always be cautious, look for meds or due to opportunity infections. A new onset headache after the age of 50, that's a late onset headache. Always look for secondary headache. And headache with seizures and headache with focal signs, you should always look for a secondary headache. So in those cases, neuroimaging is indicated. So these are the situations where the neuroimaging is indicated. And CT can be misguiding in some situations. You can miss the saccular aneurysms, arteriovenous malformations of the posterior fossa, dissections, early infarcts, all these can be missed. And cerebral venous thrombosis can be missed. And neoplasms of the posterior fossa may be ill-defined and not picked up. Meningeal carcinomatosis, cellular lesions, Arnold-Chiari malformation, and foramen magnum lesions, all this can cause headache, but CT may not clearly show the pathology. So EEG is not usually useful in evaluation of headache, except you can say whether there is a raised intracranial pressure if you are working in a place where there is no imaging, frontal intermittent rhythmic delta. If you see in the EEG, it indicates raised intracranial pressure and you can refer to a place where imaging is available. Headache associated seizures, we call it a cephalgic seizures. So seizure, headache can be a manifestation of seizure sometimes. So for that reason, we may do the EEG. And atypical migraine aura. Then you have to, you can do the EEG and see whether there is any other pathology. And episodic loss of consciousness associated headache. Is the headache due causing, that is migraine itself can present as episodic drowsiness or coma, which can be mistaken as seizure. In fact, it may be an episodic migraine. So those situations, especially in children, those situations we do the EEG. Now we will see migraine headache is the commonest headache. All the headaches I will not be covering. My aim was to know short duration versus long duration, ICP versus no ICP, ICP with focal features, ICP without focal features, and then headache, when are you going to various clinical symptomatology, what is primary headache, what is secondary headache, and then when do you image the headache, and when CT can be misguiding and imaging, MRI may be mandatory. So now we have done all the investigations and we find that our patient has got migraine headache. So we have to avoid foods containing nitrites, like preserved food, food containing monosodium glutamate, that is artificial taste makers, Chinese dishes, red wine, chocolate, chicken liver, all these precipitate migraine headache. Even the big banana precipitates migraine. So those things should be avoided. Foods containing tyramine, octopamine, strong smelling soaps, perfumes, all these can precipitate migraine. Then next is temporal arteritis. So temporal arteritis can be apparently not showing much signs and it can be missed. So always be cautious. Unilateral temporal artery, it soon becomes bilateral. Temporal artery is tender. Usually it is over the age of 50 years. Either genders can be affected, but females are more affected than males. The headache is throbbing or vascular in nature or persistent aching and burning. And arteries are thickened and tender. And a headache can be intermittent or continuous and persist for weeks to months. Loss of vision, polymyalgia, fever, weight loss, increased ESR is all features of temporal arteritis. It's an emergency headache. If you don't diagnose temporal arteritis, the patient will go into blindness. So a person over the age of 50 years More so if the person is a female. It is persistently unilateral headache and mild blurring of vision is there. Consider temporal arteritis. The simple screening tool is looking at the ESR. You can do the external carotid Doppler and a large segment arterial biopsy. And risk factors for chronic daily headache. So we have seen the common headaches. Chronic daily headache, drug over usage. So people take daily analgesics. So the moment the analgesic is withdrawn, the analgesic withdrawal headache will come. So an infrequent classical migraine becomes converted into a chronic daily headache if the patient uses analgesic. And if there is a tension headache with migraine headache. So if the migraine headache is usually 2 to 3 per month, and if there is an associated tension element, it becomes daily headache. And other comorbidities which can produce headache like sinusitis. So a drug overdose and drug withdrawal, that is a transformed migraine. Psychological factors like tension existing and comorbidities like sinusitis, dental problems, and associated sleep disorders, obstructive sleep apneas, stress disorders, traumatic life events, and head injuries. So all these are risk factors for chronic daily headache. So what are all the investigations we are going to do? CBC will help us to know any systemic infection. CRP also systemic infection. ESR for giant cell arteritis and other metabolic parameters for medical conditions, including HIV, malaria, vasculitic markers, and endocrine studies, Lyme titers, and blood levels of various drugs which might have contributed to this patient's headache. So we have to do. Then if you are suspecting a short duration headache with infection, always do the CSF for meningitis and meningeal carcinomatosis. Then subarachnoid hemorrhage, generally doing a lumbar puncture aggravates the bleeding tendency, but sometimes it is done because if it is a sentinel bleed, it may not show the classical thunderclap headache and it can be mistaken as meningitis. And then high and low shears of pressure induce headache. Idiopathic intracranial hypertension and hypotension, you have to do the CSF and measure the basal shears of pressure. Then biopsy may be arterial for giant cell arteritis, meningeal for vascular CNS, isolated CNS vasculitis. Conditions like isolated CNS vasculitis, meningeal biopsy will be needed. So now we will go for the criteria for migraine. So migraine without aura, at least 5 attacks should have happened. So before you label a person as a first attack, you don't label it as a migraine. At least 5 attacks should have happened. And attacks lasting 4 hours to 72 hours if not treated. And next is headache with at least 2 of the following. That is unilateral location, pulsating quality, moderate or severe intensity, aggravation by routine physical activity, and nausea, vomiting, photophobia, and phonophobia. Then at least one of the following. History and examination do not suggest secondary causes, and other causes rule out by appropriate investigations. And such disorders present, but migraine attacks do not occur for the first time in close temporal relationship to the disorders. There are some disorders where the migraine headache may not be temporarily associated, but it may be indirect precipitants of migraine. Then migraine with aura. At least 2 attacks fulfilling the headache criteria, and at least 3 of the following 4. 1 or more fully reversible aura. At least 1 aura symptom develops gradually over more than 4 minutes, or 2 or more symptoms occur in succession. No aura symptoms last more than 60 minutes, and headaches follows the aura with free interval or less than 60 minutes. So this is migraine with aura. Then history and examination do not suggest secondary headache, and history and examination do suggest such disorder but ruled out by appropriate investigation. So sometimes you might suspect there is a secondary headache, but you investigate and you don't find it. And such disorders present, but migraine attacks do not occur for the first time in close temporal relationship to the disorder. So you got a migraine headache, but it is associated with some other causes which is not associated with the headache. So some secondary cause might have been identified. That's an incidental pathology, but migraine is his primary problem creating headache. So additional features, gradual buildup of headache after sustained exertion. Abatement with sleep. When you sleep, a migraine headache is relieved, whereas ICP headache is unmasked. Stereotypic prodromal symptoms like irritability, mood changes, hyperactivity, inability to think or concentrate, food cravings, and hypersomnia. And regular, near regular perimenstrual or pre-ovulatory timing of attacks. So these areas the migraine can be precipitated. And family history of migraine may be there, precipitated by food, water, weather, stress, fasting, travel, exposure to sunlight, and pregnancy usually abates the headache, childbirth brings out the headache, and menopause, the headache usually wanes off. And occurrence at times of letdown, high level of activity or stress. That is also, so after you have done some activity, you have completed it, and at the end, the body wants you, do not do it. This you cannot tolerate. So that is at the end of your activity, the migraine can come, or sometimes at high level activity, or sometimes during stress. So treatment, if the headache is very mild, you have to avoid all the risk factors and all the precipitating factors. You can use acetyl salicylic acid, you can use ibuprofen, naproxen, sodium, acetaminophen, domperidone, metoclopropamide, if the attack is very mild. And you can use moderate attack, you can use ibuprofen, naproxen, diclofenac, 5-hydroxytryptophan receptor agonist, selective migraine, anti-migraine drugs like sumatriptan, rizatriptan, and non-selective like dihydroergotamine and ergotamine. And a combination of acetaminophen and codeine, acetyl salicylic acid, codeine, and caffeine, all these combination preparations are available. Then when there is a severe attack, sumatriptan, rizatriptan, dihydroergotamine, diclofenac, metoclopropamide, chlorpromazine, perchlorperazine, dexamethasone. These are useful during severe attacks. Next, we will come to cluster headache. At least 5 attacks fulfilling the B to D in the B to D, that is severe or very severe ipsilateral orbital, unilateral orbital, supraorbital temporal region pain lasting 15 to 180 minutes if not treated. And headache accompanied by at least one of the following, like ipsilateral conjunctival injection, ipsilateral nasal congestion, rhinorrhea, ipsilateral eyelid edema, ipsilateral forehead and facial sweating, ipsilateral ptosis, and sense of restlessness or agitation. And frequency from 1 every other day to 8 per day. And no attributed, this cannot be attributed to any other pathology. That is cluster headache. What is episodic headache? Cluster headache. Attacks fulfilling the above parameters for cluster headache, and at least 2 cluster period lasting 7 to 365 days and separated by pain-free remission of more than 1 month. So if you have a long clustering of headache with a pain-free interval of up to at least 1 month, you can call it as an episodic cluster. And chronic cluster, all the character of cluster headache is there, and attacks recur over 1 year without remission period or with remission period lasting less than 1 month. So remission, it is continuously there, and either there is no remission or remission is less than 1 month. Then how are you going to treat cluster headache? Hyperbaric oxygen, topical lignocaine, triptans, sumatriptan, then and preventive agents like steroids, methotrexate, ergotamine, verapamil, and lithium. Then what is this chronic daily headache? It's a chronic migraine, but a classical migraine is not a daily headache unless it is transformed by analgesic overuse. Then you got chronic tension type headache, new daily persistent headache, hemicranio continua, SUNCT, that is short lasting unilateral headache with tearing. Hypnic headache, when you are falling asleep, the headache is coming, and medication overuse headache or transformed migraine. They are all chronic daily headaches. So headache fulfilling criteria for migraine without aura on 15 days per month for more than 3 months. Then at least 2 of the following, that is unilateral location, pulsating quality, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity, at least one of the following, that is nausea plus vomiting, photophobia, phonophobia, and not attributable to any other cause. That is for chronic migraine. Then what is the criteria for chronic tension headache? Headache occurring 15 days a month with average of 3, more than 3 per month and fulfilling B to D. B is last hours or maybe continuous. And C is has at least 2 of the following: bilateral location, non-pulsatile, mild to moderate intensity, not aggravated by routine physical activity. And D is both is needed, no more than 1 of photophobia, phonophobia, mild nausea, neither moderate or severe nausea or vomiting, and not attributed to another disorder. Then in chronic daily headache, what are all the drugs that are used? We can use antidepressants like amitriptyline, doxepin, fluoxetine, anticonvulsants like divalproate, sodium topiramate, beta blockers like propranolol, nadolol, calcium blockers like verapamil, miscellaneous like methotrexate. So these are the drugs which are used for this. And what is this atypical facial pain? So it is a headache which is persistent on one side, commonly seen in females, and sensation of marked discomfort in the face, not confined to the area of distribution of any nerve, usually lower face, and seen in middle-aged females, and it is related to a tension type headache. So you have grossly covered the ICP, short duration, long duration, ICP, no ICP, and then localizing ICP, non-localizing ICP, and scan negative and scan positive headaches, and the primary headache subclassification and how to diagnose, how to investigate, I have grossly covered. So only the common headaches you can manage and you can diagnose with this small presentation meant for the younger boys and girls. Any questions you can ask, I can answer.